article published this week in AJR evaluated one institution's experience in implementing an automated CT protocoling system. This system evaluated all CT orders in the EHR and either assigned a protocol based on a set of rules or directed the order for manual radiologist protocoling. As the hospital gradually increased the number of protocols handled by the system, the percent of CT orders that were automatically protocoled increased from 27.4% during the pilot to 64.5% after full implementation. In this study, the authors evaluated the system's effect on process times and protocol error rates. I'm Andy Rosenkrantz, the editor-in-chief of AJR, and I'm here today to discuss the article with its first author, Dr. Ryan Chung, clinical instructor of radiology at Massachusetts General Hospital. Dr. Chung, thanks so much for joining us.
Hi, Andy. Thank you so much for having me here today to discuss the article. I'm happy to be able to share the work that we did with your readers.
Can you describe for us how this system worked?
Yeah, of course. So I think it first helps to just quickly run through how manually protocoling works at our institution. Normally, the order is first entered into the system by the provider. That information then goes to our web-based system where it gets assigned to a queue for one of the subspecialty radiologists. And then usually a trainee has to protocol that study based off of the order information that's provided to them. Now, that information could be sitting on that list for a while, depending on when the trainee has access or when they've reviewed that protocol, or they could protocol it immediately, depending on if they're looking at it at that time. So the thing about our automated protocoling system, it's similar in the sense that it also begins with the ordering provider placing the order entry. But the difference is that the information that's provided by the order in the system, including patient information as well as clinical information, then goes to the automated system where it gets checked by a couple of different systems. So there's a couple of different rules. And if there's an applicable rule, the study will get protocoled based off of the information provided in the order. Secondarily, there's another check where if there's an exclusion or a blocking rule that will then cause that study to be blocked by the automated system, it then gets directed into the manual protocoling system. If it otherwise passes those checks, it then goes to the EHR and goes to the technologist workflow. And from there, the technologist can go ahead and perform the study as protocoled by the automated system. Like I had mentioned, if it doesn't meet any of those rules or there's a discordance between the order entry and the actual order indication, then it goes to manual protocoling for review by an actual radiologist.
The mean times from order entry to protocol assignment and from order entry to exam completion were lower for automatically than for manually protocoled exams in the ED, inpatient, and outpatient settings. Can you comment for us on the importance of those time savings?
Yeah, I think that's really important to highlight. It kind of goes back to what I had mentioned before about the manual protocols. So in the inpatient or ED setting, the typical workflow would be an order is placed, and then it would rely on a radiologist to actually look at that protocol list and protocol it. Until that protocol is assigned, the CT technologist cannot call that patient down for the scan. And so they may be sitting in the ER or in the inpatient floor waiting for that study to be protocoled. And you can imagine that would lead to some delays. And so one of the advantages to the automated protocoling system is that doesn't rely on a radiologist to actually protocol the study. Instead, that can happen behind the scenes while the radiologist is maybe reviewing a study or in consultation with another provider, and it's essentially immediate. And so those protocols can be assigned. The technologist can then call the patient down, and that has downstream effects on the care of that patient. They don't have to wait in the ED as long for that particular study. Their care may be expedited. They can potentially have their disposition set up more immediately than if there was a delay. On the outpatient setting, there is also an impact. One of the things that we encourage the radiology trainees when they're protocoling is to look at studies and make sure that they get protocoled greater than 7 days in advance. Now, sometimes that doesn't happen and the protocol gets assigned on the day the study is performed. And that has some potential disadvantages. One of those being if the patient needed pre-medication. If they didn't have that study protocol ahead of time, they may not have been ordered for the pre-medication. They may not have been reminded to take their pre-medication. And then when they show up for their exam, they may not have taken it. And so that either results in them getting rescheduled from another day, or the exam is modified so that they don't get contrast. And so you can imagine how that can disrupt the workflow and can make it challenging for patients to actually get their scans. And so again, the automated protocoling process protocols it so that it increases the likelihood that they'll have the exam protocoled on the day of their exam.
The number of QI reports and recalls were low for both automatically and manually protocoled exams. Radiologists retrospectively reviewed a random sample of protocols and agreed with approximately 99% of both manual and automated protocols. Can you comment on those findings?
Yeah, that's a good question. And an important thing we wanted to highlight is it's one thing to have an automated protocoling system that changes the system, but we also wanted to make sure that it was actually accurate. And so a couple of the ways we assessed for error rates was, like you mentioned, assessing the number of QI reports over the study period, and also looking at the recall rates. And then we also wanted to look at the retrospectively reviewed cases to see if there was concordance between what was originally protocoled and what was protocoled by some reviewers.
How may the system improve workflow and efficiency for radiologists?
Yeah, so this system also improves the workflow for radiologists by allowing the radiologists to focus on things like their interpretive tasks. So interpreting the studies, or potentially, discussing cases with the referring providers. You can imagine that when there's an error in a protocol or maybe a discrepancy, the technologist in the manual protocoling system, what they'll oftentimes do is they'll call the radiology reading room, ask the radiologist to provide an urgent or semi-urgent protocol, and then that can be disruptive, right? So that can take the radiologist away from actually looking at the study they're looking at, or take them away from having a discussion with their referring colleagues. In addition, if the radiologist is in a discussion with a trainee, for example, that could also disrupt that educational role that they have going on. So with the automated protocoling system, ideally, this allows the protocol to be assigned without the technologist having to contact a radiologist. And then, that leads to decreases in the disruption to the radiologist's workflow.
You also comment in the article that the system allows greater standardization of protocols than achieved through manual protocoling. Can you tell us more about that?
Yeah, I think it's just human nature when someone is protocoling a study, that they kind of rely on having a few limited sets of protocols and trying to take the most relevant information to decide which protocol is assigned. Now, it's when you're busy, when you're seeing a lot of patients or reading a lot of cases or having a lot of distractions, it's easy to miss some of the other information, maybe allergy information, EGFR, renal function, and also focus on a couple of few limited types of protocols. What the automated CT protocoling system allows us to do is it takes all that information without any kind of biases, without having the distractions of things that might distract a radiologist, and it allows the system to incorporate that information and choose from all of the system's protocols. Some of them more complex, some of them less often used, and some more often used. So there's no bias in the protocoling system. It allows the system to really be able to take all that information and pick from those sets of protocols without having to worry about missing something.
You mentioned earlier trainees. In your experience, how does the system affect trainee education?
Yeah, that's a good question. I think a lot of us know that there is value in protocoling studies for trainee education. It helps you troubleshoot a case, helps you understand why a protocol is done the way it is. And so there is definitely value in protocoling cases. But there's almost so much value that you can get from, like a routine type of case. For example, if it's a patient who has flank pain and they are looking for renal stones, you do a CT renal stone protocol, right? You learn it once and you get the knowledge from that, the education from that experience, but it doesn't really take a lot of thought behind the protocoling in that particular situation. So ideally what the system does is it actually handles all those mundane or routine protocols. And then if there's some complex case that can't be simply addressed with the checks or the exclusions that we had mentioned previously, then it goes and gets pushed to the manual protocoling list. And I would argue that those probably have the most educational benefit for the trainee because they're not simply, is this patient having flank pain and is there a concern for a kidney stone? There's more complexity to it. Maybe the patient has multiple types of cancer that require different phases of contrast or different ways of evaluating. And so that I think is the value in the system. It gets rid of the mundane tasks, but allows the trainees to still learn from the more complex and challenging tasks.
What is needed for readers who want to implement such a system?
Yeah, so our system is fortunate enough to have a really strong team of both radiologists, CT technologists, and IT engineers, which I think are crucial in order to be able to implement something like this at another institution. Some of the software that we used was proprietary and reserved for just for our institution, but I think the key thing is really being able to have a good electronic health record, as well as a strong team of people who can kind of collaborate and work on coming up with different types of rules. I think one of the big things also is that there's a lot of trial and error in this kind of system. We can't anticipate all the different rules that might apply to every single particular case. And so that's where having the good team of people who can anticipate some of those cases, but then also willing to review the feedback that we get from our radiologists to be able to make changes in an iterative process and make changes to improve the system. So I think the big thing would be having a good access to electronic health records system, as well as having a good team of both radiologists, CT technologists, as well as IT engineers.
What do you anticipate as future system enhancements?
Yeah, so part of the process is iterative, as I had mentioned. And so we're constantly trying to get feedback from our radiologists in terms of whether the automated protocoling system is functioning appropriately. And so one way that we're trying to improve, and I think that our system will be enhanced further, is just keeping the stakeholders involved, like our radiology colleagues, to be able to improve the system and give us feedback so that we can make changes. But I think one of the other interesting things that we can potentially use is trying to incorporate some sort of a hybrid system where we have both this rules-based approach as well as having a machine learning approach for situations where we don't necessarily have a rule, or if there's any kind of gray area, it would be nice to have some sort of machine learning approach to be able to kind of tackle those kinds of situations. But that's not currently implemented, but it's something that can definitely be incorporated down the line as the system continues to evolve.
Dr. Chung, thanks again for joining us.
Thank you, Andy. It's a real pleasure to be able to share our research and share our system here with you and your readership. And thank you for giving us this opportunity.